Hello, my name is Michael Davidson, and I will be talking about caregiver role strain theory. I work on an intensive care unit step-down unit, but also the primary unit for stroke patients in the hospital. So in the U.S., stroke is the leading cause of disability for patients. And in terms of caregivers and the responsibility they have at home to provide for these patients, they have the possibility of having physical, psychological, and the financial stress of being the primary care for a stroke patient. In terms of the four meta paradigms of nursing, the first is person, and the interaction between the patient and the caregiver is important because they can have a dependent relationship on each other. So the caregiver now becomes an unpaid informal caregiver as the patient is transitioned from the hospital to the home setting, where they will receive all care that a nurse or patient caretaker that we have provided with support of resources, but become really the main person and provider of care. In terms of the environment, the transition from a hospital setting where nursing staff is providing the safe environment for the patient, the caregiver now has the burden of providing safety for the patient in terms of the logistics of the home, positioning, free from any falls or self-harm, and most importantly in a stroke patient is the risk for aspiration or any signs of dysphagia, or making sure that they are taking oral intake appropriately. So the burden of the care in terms of safety is now on the caregiver. The health of the caregiver is important because in order to have a healthy patient and provide care, the health of the caregiver needs to be maintained. And they might have a primary stress of the ability to provide care and the knowledge to provide that care, which could lead to secondary stress of depression, anxiety, and just the general stress of being a primary care provider for that family member or patient. Now, the nursing aspect is the attention to detail that is required for a stroke patient in terms of injury prevention, maximizing their self-care, limiting any declining function, and really the overall safety and nutrition of that patient now falls on that caregiver and the role that they provide. So why does this fit? Why does caregiver role strain theory fit in my unit? Because the stroke patients may have been fully functioning and now require a high level of care and become a total care patient, which puts a lot of strain on the family. So how I can influence my practice is education. Families that are going to be taking care of a stroke patient, providing appropriate education before they leave in terms of proper nutrition, body positioning, care for their skin, and making sure they're clean and dry, turning schedules, so they can transition the care and prevent any decline of that patient. The second time is engaging resources that they can leverage as the primary care of that patient to get relief, ways to manage stress, coping mechanisms. So engaging community resources and our case management to make sure all available resources available to them can be provided, as well as encouraging other family members to take part in the care of this patient. So overall, caregiver role strain theory is very applicable and a concern of mine when stroke patients have to transition from the hospital to